Welcome to our battle of the EAO Online Congress in Geneva. I'm currently joined by two eminent experts in the field of prosthodontics. First of all, Vincent Fehmer, a master dental technician at the University of Geneva and co-author of currently the hottest textbook in dentistry called Fix Restorations. Welcome, Vincent.
Thank you very much.
And on the opposite side, Daniel Edelhoff, Director and Chair of the Department of Prosthetic Dentistry at the University of München, and, fun fact, triple recipient of the Best Teacher Award. Welcome, Daniel.
Thank you, Gary.
We just had a session. You are the perfect experts to take us on the battle between digital versus conventional technologies in the fabrication of restorations. However, before we dive in, I would like to point out that the battle remains a battle, yet not between Vincent and Daniel, who take sides, but rather between the concepts of conventional and digital and their actual limitations. So let's get started with the very basics. Can you explain to me what is actually the key difference between a conventional or a digital approach in the fabrication of restorations? Who would like to start?
I mean, we can start in the laboratory if you want.
Please.
Because the main difference here is that we have been moving on over the last years, and especially in the laboratories with the introduction of zirconia, these new technologies has been, taking place like really substantially, and it has become part of our daily routine. The main, let's say, breakthrough has been happening in our entire dental field, the way I see it, and I'm really curious on your point of it. Once we started taking the impressions no longer in a conventional approach, meaning by silicons or alginates, by having these little cameras that help us to digitize already the patient on the chair side. So that really made a change, and with that change, a lot of new things had to be applied and enrolled into the laboratories, because there was nothing more to fill with plaster, and therefore there was no chance to actually start in a conventional workflow. So where we came from, where we had figured out how the whole workflow, how it was functioning, applying lost wax technique, all these aspects that we had taught ourselves over the years, now we were there actually having to handle these direct digital data that came from our clinicians. And that was, to me, the game changer. That was the moment when I decided personally that I have to invest into printing technology. I have to invest myself into the understanding of these new technologies in terms of the materials that we have on hand, and then fabrication technologies of these new materials.
Exactly, makes sense. All of a sudden, there's nothing to work with in your hands. You get a digital impression.
Exactly.
Now you need to design and work digitally as well. That's the technical perspective. Daniel, if I may, from a clinical perspective, what is the important difference between that conventional and digital workflow?
I have to say, if I'm honest, I'm a hybrid dentist. So
what does that mean?
That means that I still work a lot of analog procedures, like preparation technique of the tooth, for instance. So I prepare. So until this step, it's the same. Like Vince said, then you could start your digital workflow by intraoral scanning, of course, to digitalize directly. But I can also indirectly digitalize. So I take conventional impression, and some indications still valid to do that. So for me, the main reason going digital is the laboratory, because they can give me some killer applications for analog. There are materials available that I would never could access with an analog approach. Zirconia, hybrid ceramics, but also new high-density polymers that we heard in our the lectures today. And this is something which really extends the spectra of our treatment options and concepts.
Exactly. So let's dive in. The session that took place here in the physical congress in Geneva kind of followed these three steps. We talked about fabrication with Marta Revilla-Leon. Then we moved into the new materials with Burak Yilmaz. And then we ended on the opportunities of monolithic solutions. So let's start with that first part. You already started with I obtained a 3D printer. And Marta told us everything about where we are in terms of 3D printing. What is the key thing that you took away from her lecture?
For me, the key thing is, besides seeing this fantastic research that she has provided us, it's the printing technology is definitely here to stay. This is the base information that every clinician, every technician has to take home. You cannot foresee the next 5 or 10 years of your career in a way avoiding putting yourself into this technology. What I also take away, and I think that is also very critical and crucial for I think the user to understand in the end, is that the printing technology is more than just buying this device, running an STL onto a platform and then trying to press a play button. There are so many crucial steps, the way that you position the printing goods inside your printer, the angle to it, the way that you attack it by means of the support pins, the liquids, then the post-fabrication, the post-manufacturing, meaning the cleaning of these final goods that we then produce. It can be surgical guides, stents, models, whatever it is. There is crucial aspects that we have to learn, we have to invest ourselves into in order to really to utilize it up to the highest potential. That is, for me, the lesson that I took away from Marta. First of all, it's absolutely crucial for the future, because without this printing technology, I'm dry in the laboratory. I cannot work just on a final restoration in my hands without having any support material. And the efficiency of these workflows really only pan out once I have this printer on site.
Exactly. Very promising technology,
Yes.
very advancing, but also quite some limitations still, work in progress. What would you say are the key limitations and at the day here and now?
First, perhaps I can mention one benefit in the clinical step, perhaps, Garrett. So when we take intraoral scans, we capture also colors. We capture 3D informations directly, so we can print even multi-material models if we want, with different colors, with the real colors of the teeth that I prepared. So the limitations, you said, is still, I would wish to have a system which gives me the opportunity to create permanent restorations, and we are not there yet.
Yeah.
We heard this, and
We heard the biggest limitation is actually aging of the material.
aging of the material. Sometimes perhaps we call it illusion. They are coming out parts of the material that we don't like to have it in the oral environment. So it's a lot of work. Marta was very honest, and I think she made us two specialists in this field. And therefore, I would wish to have a permanent material, which gives me a lot of advantage as a clinician, but we are not there yet. And this was a lecture which gave us a standpoint, a moment of research, and I'm very grateful about that.
Yeah.
Vincent, as a technician, do you think in the end we will completely abandon subtractive technologies and fully go all in on 3D printing?
I mean, I tell you this with partially bleeding heart, because, as a technician and all my fellow technicians, we have invested a lot of money into these milling units. We are talking 50,000 euros upwards. So still, I have to say that I absolutely agree with this statement. In maybe 5, 10, 15 years from now, I'm certain that we will print zirconia, maybe even lithium disilicate, on a level that it will be, in a way, applicable to the laboratory around the corner. So they will be able to afford systems that can produce such things. Today, this is maybe taking place at university levels, because there is maybe the technology, there is the financial means or the financial support to obtain it. But I have to clearly state that in the future, we will print final restorations. I'm 100% certain on that.
Exactly. And Daniel, from a clinical perspective, Marta showed us several clinical applications, mainly towards scan bodies, guides, that kind of stuff. Before we hit the final restoration phase, what other potential developments do you see within the 3D realm?
The main advantage should be that we can create a prototype of the final restoration that we test drive, and we can scan it, rescan it. So, for instance, we can put it into the patient's mouth, like we discussed in our discussion with Francesco, and the patient can imprint, engrave the patterns, the wear patterns, because we were working with the final stage with zirconia monolithic, for instance, with a material which needs years to have this wear facet. So this gives very important information, not only functionally, aesthetically, phonetically, and the predictability is much higher in the future.
Yeah. Test driving the final restoration, the intermediate restoration,
Absolutely.
so to speak. That really ties into an audience question that came from the room in this session as well, because I can already imagine if I'm grinding off my temporary restoration, a lot of that material will end up in my mouth. What can we already say, and it's a nice bridge into Burak Yilmaz's talk about materials, about the biological safety of all these new 3D printed materials? Daniel, Vincent?
Maybe you want to address
Yes,
this
we
first.
have heard there are options to verify scientifically the biomaterial properties. And so long if we have not standardized the whole process, the post-processing is a very mandatory part of the whole fabrication, and there we have to standardize much more. There should be no shortcuts to avoid certain steps, to make it faster or something. So it must be standardized in the whole closed process. That's my personal opinion. And then we have a good chance to have a biocompatible material.
And that is, I think, something very, very important that Martha mentioned earlier on. Because she clearly said, now we become manufacturer of something. So we produce something. That is completely different than being subtractive, where we buy some discs from the industry that produce this disc, and the only thing we do, actually the only, is chopping it down. So that is something that is extremely crucial, because what happens is the way that our, let's say, environment functions is that laboratories, they will acquire this technology, they will have a training period associated to it, but then you're off by yourself. And a lot of knowledge when it comes to these aspects is still missing, because this technology is penetrating the market much faster than the research comes behind it. So that is a kind of a, I don't want to call it gray zone because it's shady, but it is kind of a gap we are currently in. And that can be really critical. On the other hand, I think I still also see that we are using this 3D printed technology as support material, at least at the moment. I think the most permanent things that we deliver mainly to our patients might be Michigan splints that are printed. But on the other hand, it might be on a base of a provisional, it might be on the base of a surgical guide, these kind of things that maybe are exposed to the oral cavity for a few hours or overnight or in that kind of a scenario. Not so much like the real final scenario that we all dream of is having the real final restoration based on a tooth or an implant given to the patient, and then that's it.
And then we're done. Yes, exactly. And then let's dive into that second topic of the session, the new materials and the opportunities and limitations of that, presented to us by Burak Yilmaz. What have you learned from Burak in a sense of where are we, what are the key opportunities, and what are the key limitations here?
I mean, I was happy to see that, because I'm always stunned. There is usually we have the IDS every 2 years. It's a huge dental fair, and the industry is overloading us with new types of materials, even new indications, not only subgroups, but completely new fields. So what I was very happy to see is that basically he summed up what we saw then also in the conclusion of Federico, because here zirconia seems to be the clear leader here when it comes to the final prosthesis.
It's being talked about as the ideal dream material for everything, right?
Nothing comes perfectly with only one side of the metal, we all know that. But when it comes to final fixed restoration, zirconia seems to be really the preferable. Not easy, but easier in the production. Once you have figured out, the way of engaging it, the laboratories are able to produce it. While all these new materials, the peaks and the pegs, they have their indications clearly, but to my understanding, mainly focusing then on removable parts that patients wear and maybe are able to take out and clean, and they have to have other probabilities and other indications that zirconia don't have.
Exactly, because Burak compared several materials based on their accuracy, their wear behavior, their color stability. Any new insights? Do we see new opportunities besides zirconia, Daniel, or is it zirconia all the way?
I'm still like to not forget lithium silicate.
That's what Burak started with also,
restoration. So still aesthetics and chameleon effect are superior. And I was very excited that he still mentions the press technology. Because if you press something, you can make it safer than CAD-CAM, a very thin margin, for instance. So it's not dead, from my personal opinion. But for the future, I think we are still talking about milling. Zirconia, it's not pressed, it's not pressable, it's not printable in a high level. But for the future, I would see ceramics with different material ingredients. That means the difference between milling and printing is actually that during the printing process, you can stimulate, you can evaluate or change the optical and the mechanical properties. So let's say for a single tooth, you can open a dentine core and put something enamel on it in one process.
Yeah.
That would be perfect for the future. I mean, this is bio simulation, yeah, and this is something I would wish for the future. And I see a lot of options that we can in the single tooth restoration come very close to the nature with different behaviors of dentine and enamel represented in the final ceramic.
If I may add to this, because this is really hitting the battle point now, which is good.
Yeah.
Lithium disilicate is absolutely opposite of that, especially ones focusing on teeth, to my understanding, and defect-oriented preparations, veneers, and all these things. But the problem here is the production of lithium disilicate, especially linking it to any kind of implant abutments, with their very, let's say, special shapes and geometries, is extremely difficult for the laboratories and the milling units in the laboratories.
Why is that, Vincent?
Because it's a very hard material already in the pre-sintered stage, in the violet stage, as you know, it might be very familiar to the audience. And the milling machines have a hard time to then, come up with geometries that fit on those kind of tie bases that are very well received by all the clinicians and laboratories. So there is a constant battle from the laboratories towards the clinicians to only use zirconia, because it's so easy to manufacture, it's so easy to handle in the process of a laboratory, and a constant battle backwards to the laboratory to why don't you use lithium disilicate? Because just like you said, the chameleon effect, integration, especially for single teeth or single implant restorations, it's still the preferable option. So if you ask me personal, I'm in need of a crown, I would certainly go for lithium disilicate.
And there's another aspect as well. So it's a strength. It's not too strong. This crown, we do some investigations on.
And now you're talking about the lithium disilicate, right?
Lithium
exactly.
disilicate.
Let's be clear what we're talking about.
Yeah. Compared to zirconia ceramic. So we have seen that that's a favorable failure. So in vitro at least, and sometimes in vivo only casuistics, that crown fractures before something others happens, like screw fracture or abutment fracture. Might be it's a nice material from the strength standpoint, which can be also reproduced by zirconia 5Y TCP, for instance.
That's true.
But I like to have a material which protects the implant in the crash. Yeah. So it's a favorable failure, and
because obviously the chain is going to break at the weakest link.
Exactly.
And you say I rather have the weakest link in my crown than either in my abutment or in my implant.
And I can reproduce because I have all the data in the lab. So it's like if your car something is hidden and you place a new part on it. Yeah. So this is a new thinking. It's applicable on implant dentistry, but not on natural teeth just now.
Yes.
But now I'm not sure if I'm getting smarter or more confused, because this is a battle. So you say on the one hand, the technician tells me zirconia, ideal material. It works ideal in my lab. Yes. It has beautiful qualities in different aspects. Yet you say, well, maybe from an overall perspective, it might be smart to not put such a strong material in the crowns. Vincent, what is your response to that?
The problem is, the main issue that we are facing here, and that also the audience has to understand, is that when we are focusing on a single implant restoration, there is all the variety that we have on hand that we can apply. The moment we scale it up, already just to a 3-unit bridge, lithium disilicate is off the table. So we are already down to oxide ceramic zirconia. And I think that is something clearly that we have to state. But as a day-to-day business, single implant restorations is a main thing. You know, doing these full arches, luckily, at least to my understanding, I see them very rarely, and I'm happy because it makes you sleep bad. It's a tough time. Yeah. It's not easy. And if something goes wrong, it goes wrong massively. It spills down a lot of time down the drain. And that is the critical parts. And that is something that is important to understand in that discussion.
It's good you put that into context, right? Let's all agree what we talk about. So Daniel, back to the clinic. Now that we talk about more complex cases, for example, full arch. Anything in terms of innovative materials that you prefer there?
Yeah, still we are looking for zirconia full arch. In the beginning, we criticized a lot these people presenting these large horseshoes,
yes.
say.
Yeah. Why?
Why? Because it's a very difficult approach. Vincent will explain very well, because the sintering process, the furnaces cannot bring the heat into the middle of a very volume-like restoration. And there were a lot of fractures. In the beginning, when I talked to a laboratory, they said they have to pay the double, the dentist and the patient, because I have to redo it after a certain time period. Now, I think we are much more smart. We know the weaknesses, and it works. But if you go safety, I'm still a friend of a metal framework with something on the top that you can exchange, for instance. But if you have any doubts about the forces, but I'm happy to hear that more and more the success rate of these horseshoes becoming better and better. Yeah.
And I think, Daniel saying he's a hybrid dentist, I think also when it comes to these concepts, what is always critical and crucial to me is that we are not trying to put everything in one box. So zirconia seems to be a fantastic material. It doesn't naturally mean that we have to apply it in both jaws. So we can also think in hybrid ways of maybe having the zirconia and the preferable aesthetic. It's not affected by staining and all these issues in the upper jaw, which is also very crucial for the patient, also due to the angulation of the lower bite. It's the preferable teeth that would fracture. Zirconia certainly will not fracture. And we can think of something hybrid, metal-based denture teeth in the lower that then maybe ends up with a little more maintenance over the years to come, replacing of these denture teeth, and then combining these two concepts, avoiding the clinking effect, avoiding a lot of those issues, and also limiting the price, making it more accessible to more people. So
you mentioned price and timing and time, and that brings us to the last part of the session that we are reflecting on. Francesco Mintrone talked about the monolithic restorations, putting it all in one piece and putting in. What are the key opportunities and limitations that you learned from Francesco?
I mean, for me, what he has been so phenomenally, beautifully shown in his, he's absolutely gifted with his hands. The collaboration he has with his technician is the top notch that you can find. But what is very important, and the message that I learned from him and that I take home, is the predictability in the fabrication process. So whatever he invests into the diagnostic aspects, you see the 360-degree face scan, the prototypes that he takes on the patient, he makes the patient aware of the process. And only once, he went through these excessive protocols, he goes to the final delivery of the final prosthesis. And then you are able, with today's technology, to actually deliver the same shapes, the same contour, the same occlusion, just as has been promised to the patient. Exactly. And that is the main differentiator for the laboratories, that today we are predictable because we have materials given to us by the industry that look teeth-like. And that is especially the strength for zirconia-based restorations.
Because Daniel, are we ready to, in terms from an aesthetic perspective, is monolithic, even in the aesthetic zone, is fully feasible, you would say?
I think Francesco explained it very well. To my personal opinion, I absolutely agree. We need it, if you do a full arch, it's much easier working with monolithic zirconia because you have not a reference competition, natural competition. And I like this aspect with the microlayering. I think this is for the next years the future, that you in the anterior aspect with all the aesthetic demands, you need a micro layering to have a higher translucency, not coming from outside by staining, coming from inside. And however, you can get all the guidance, the functional guidance in zirconia, which is polishable, which is strong, and which is, has a permanent stay at this situation. And I think this combination, Francesco showed it very well in the last case, is the future for the moment, for the next years. Yeah,
exactly. Now, one of the interesting drawbacks, perhaps, of a monolithic solution came from an audience question as well, Vincent. There might be an issue with an active nightlife. What is that?
The active nightlife is certainly something that we hope that all of these, let's say, patients will have and enjoy with their new teeth. But the problem is that zirconia per se it has already a tooth look-alike color. You know, they have even the gradients that move throughout from a more dentin-like base towards an incisal edge that is more aesthetic and more translucent. But what was the question focusing is the fluorescence, the natural
Exactly.
fluorescence of our teeth. So if you
Here
are
we walk into the nightclub tonight, and all of a sudden my monolithic restoration lights up.
no, actually, that is the problem. It will
It
not
doesn't light up.
So you will
Thank
be
you
in
for
total
clarifying.
darkness. So if you are in that situation, don't smile. It might be less
That's
fun.
exactly the problem we're trying to solve for.
Exactly.
patients,
So
right? Yeah.
there's basically two workarounds. I think even three today. The industry today even offers fluorescence zirconia blanks. So
Yeah.
the fluorescence is already embedded or infiltrated into the zirconia. The second option you have on hand is actually infiltrating it manually by the hand of the technician. This is never something that is really highly standardized, so it's something I personally try to avoid because I don't want to have certain spots that are then
Right.
highly fluorescent while others are not. And finally, I think what Francesco also highlighted in his reply to the question is that applying a microveneering, even if it's just 0.3 millimeter of ceramic or just glaze, already in the glaze, the fluorescence parts can be incorporated, and thereby you solve that issue. But I think that the crucial part is that we don't have to neglect it, we don't have to forget about it, and we certainly should not just polish the buccal face of the zirconia that then will put the patient in that difficult scenario.
Exactly, and it's a bit of a rare scenario, but
Yes.
it is maybe actually the scenario that is very relevant to that specific patient.
Nightlife could also mean grinding.
Nightlife could also mean grinding. That's a nice addition. All right, when we wrap up, if we have spent so much time on digital versus conventional technologies, what would be for both of you the key takeaways that you take into your offices next week? Daniel, for you as a clinician.
Yes, I think I will keep for the next years, next 10 years, a hybrid dentist. And that means I'm working analog, not a robot who will do my preparation, and I need empathy for my patients. So we start analog, then we go in a digital cloud, I would say, and Vincent will describe,
Do you
and I
mean
come
my
back analog.
diagnosis will remain analog, your impressions, or where does that analog
no,
stop?
No, this depends on the situation. The moment the short arches, no problem with digitalization directly in the patient's mouth. Even full arch is possible, like we have seen by Martha, some nice approaches. This is not, but the preparation, I would say. As a dentist, I will keep analog in the beginning and at the end because I have to screw it in. Yeah.
Exactly.
So
exactly.
but the main part from the digital working process will be in the lab.
Yeah.
All right, so Vincent, from your end, key takeaways for next week in the office.
Key takeaway, being in the lab of the future, you need to have that technology. You don't need to be able to do the whole picture. So there can be still some outsourcing by, indicated manufacturers that can do the full arches maybe and can mill them and can produce them for you. But on a base, you need to have the printing technology to produce the models, to produce the support pieces, and you need to have the means to come up with this monolithic restoration, and that implies CAD/CAM technology and the fabrication of the final restoration. If you don't have that, you will not be able to bring up this efficiency that is needed today, to compete with your colleagues next door. So that is the crucial takeaway.
Exactly, and I think in the future we'll have more sessions where we talk about what it means that we all of a sudden become now a manufacturer,
Yes.
and all the aspects that come into medical regulation as well. Well, thank you, Vincent. Thank you, Daniel, for this very interesting session. And thank you for watching. I really hope this session helped you to make the right choice for the right approach, and always based on solid scientific evidence.